I would really prefer that somebody, live a healthy life from an adolescent into adulthood and don't ever need, medications. That would be my preference. That said, there is a place for medication for people that need them when they need them. And metformin, for me, seems to be one that is pretty maximally beneficial with not a lot of like downsides as far as I understand. Would you agree?
Yeah, so it's interesting. I was probably like you, Casey. I was an avid medication non-user, fix it with lifestyle changes and, how you eat and live and sleep and whatnot. And I, wasn't a total choir boy. Worked hard, worked late. I did a lot of sports that, were a little bit dangerous too, mountaineering, whitewater kayaking and that kind of stuff. But about probably through working with Travis and Care Oncology and sort of looking at this back data, and I was like, well, you know, I was very dismissive of the data with statins. Because when it first came out, I don't know if you remember the Time magazine, one of the beauties of like studying economics and understanding statistics and math is, I always kind of looked at the value of this to an individual. And I would always try to organize things into NNTs, number needed to treat. How many people, if I treat with this, will it benefit? Because I have my own little sense of if I'm going to get benefit 1 out of 50, and it means preventing a recurrence, that's sort of like an airplane in the wind. That's a very low probability. Now, when the Time magazine came out, they said, like 34% reduction in cardiovascular events or death from cardiac events. That sounds really powerful. 1 out of 3, 35%. But that was a relative risk reduction. That compared those who got the placebo versus those who didn't, who got the drug. And really it helped somewhere between, if you looked at the air bars, it helped as many as like 1 out of 35 to as 1 out of 130, and so that was in the zone of walk away from that. But it was only at like a 5 year juncture. And there's an expert in lipids, Dr. Snyderman, who has kind of looked at it. He's a big advocate of looking at ApoB more as a marker than LDL or other markers. And if you look at the 30-year return, the NNT really improves, mainly because we're all going to get, never say never, never say always, but most of us are going to get some sort of blood vessel disease that's going to affect the brain or the heart or distal extremities. And that number needed to treat drops to one out of 7 at 30 years. So to me, that starts to get pretty relevant. If I can knock out vascular disease, and it's not going to be all or none, but the death from cardiovascular event, is improves 1 out of 7 at 30 years, probably is helping a lot of people's blood vessels in a less than causing death way. That becomes a better consideration. And then you can, follow markers and look at it that way. Like I just had a talk with my son who's just hit 30, and he's, a bit of a modified ketogenic guy. He lives really clean, but he had a high ApoB, and I said, we might want to consider some early statin use for yourself. Now, metformin, we're all waiting for the TAME trial where they took healthy people and they put them on either placebo or metformin, because the original studies, were people with, presumed diabetes showing a marked improvement. And kind of the reanalysis of that is, there's some questions around it. But for me, you're right. It's cheap. It's invisible to, I don't notice having any side effects from it. I take now a low dose statin and metformin routinely for prevention of disease. I think the two have some synergy together. Um, I kind of go back to this trial from Taiwan where they found, hepatitis is very common in the Orient and Asia, and hepatitis is a viral infection that elevates your risk of many cancers, especially liver cancer. And they had 70,000 people that were Hep positive, and they looked at this big data set because everybody's on a national healthcare system there, and it turned out that a big block of people were on a torvastatin or a statin, a big block of people were on metformin, but they had 5,000 people total that were on both. And if you happen to be on both of them, now granted, population studies aren't perfect, but if you happen to be on both of them, your rate of the like 10 most common cancers went down dramatically. Um, and so that was pretty relevant. I mean, the lowest amount it went down was like 28% compared to people not on both of them. And if you're on one of them, it helped modestly. But if you're on both of them, it was a powerful effect. And
Wow.
so it's sort of the bet I'm hedging, kind of figure this out. As you said earlier, they're not going to do clinical trials on this. They're doing a trial for metformin. And and then once again, there's some trials out there for, as I mentioned earlier, on this other, drug that's out there called sirolimus or rapamune, and that looks very promising. Uh, there's a molecular uh, testing organization. I believe it's called ITP, and it's 3 labs around the country that have best practices. They use the most, you know, lab animals for testing can get so inbred that it doesn't really reflect normal biology that might reflect what might happen in a human. But they use sort of the least inbred version of the lab mice. There's whole science behind that, and they test molecules. And they've tested resveratrol, they've tested metformin, they've tested NADH, they've tested the 17 estradiol, and rapamune. And rapamune had some of the best results. They actually tested it in the chow daily, and one of the most relevant things about it was they had some problem getting it in the chow, and making sure it didn't get broken down in the acidy digestion process. So the mice got older, and they're like, oh, we maybe don't even want to test them because you know we don't usually start with mice that are already 3/4 of their normal age range. But they did it anyway. They found that there was still like a 35% improvement in survival, even though the mice were like 3/4 of their normal age. So kind of extrapolate that to a human, which is always a little bit dangerous. For like a 60-year-old fella or a woman, it might be beneficial. Usually we think, well, the die is already cast. You should have started at 40 or 30. But, that looks impressive that you could start that late in life and have some impact. So more to, the story's yet to be told there, but a lot of excitement around that.
Interesting. Okay. You're kind of blowing my mind on something that I don't think I've ever like really considered. So I'm so excited to ask you about this. The statin thing. This comes up on our show all the time. A very prominent cardiologist. I don't need to use a name, but and I know, and everybody listening probably knows who he is. He's a longevity expert. He's written an amazing book about longevity, and everybody in the low carb space is like, okay, I'm on board with 95% of everything this guy's saying, but he's still saying that he's very pro statin for some people. And we have this cohort of people in the low carbohydrate space. It's not many, but it is some, that if they have a low enough BMI and they go low enough carbohydrate, their LDL cholesterol goes really, really high through the roof. Thus, their ApoB is also going to be very high through the roof. And so it's this kind of push and pull of like saying like, okay, I thought the number needed to treat was 229 with a statin, but I had never considered the longer you use it, the better that number gets. And that is an interesting justification of
Yeah.
taking a statin I had never really ever considered. Would you be concerned about lean mass hyperresponders and their kind of like, I don't know, like not necessarily resistance, but almost like this like air of like celebration that their cholesterol is so high?
Yeah. So, it's interesting. There was just a paper in one of the longevity journals. I got it on my phone, but they looked at the the laboratory values of centenarians, and they had a great big, I think it was Swedish population where everybody's in the same, EMR, electronic medical record, and they looked at the markers that were of those people. There was like 2 to 3% that made it to over 100, and high cholesterol was one of the outliers. So it may be that higher cholesterol, and this is just total cholesterol, is a predictor. In some ways, it's protective. Now, I would say for those people that are hyper responders, don't so much worry about your total cholesterol or your LDL purely. You know, it, I like the Feldman ratio. It's the triglycerides over the HDL. You want that to ultimately be one or less. You want an HDL that's higher than your LDL. That's a prediction of very low risk, even with a background of family history, diabetes, hypertension, or smoking, which, you know, some of that is in the past. You can't fix that. But also, I would also say it's not a bad idea to look at, and I'm not a cardiologist, but I just read a lot. Once at some point, get an LP little a, and that's a submarker. It's a little lipo chain that is, I guess, apparently very inflammatory. So when you know LDL goes to to bring healing cholesterol to like endothelial lining, areas of turbulence or break in the lining, this somehow creates inflammation. And the statistic that I have heard is that if you look at those people that die of sudden cardiac death, meaning the first symptom is, they flatline, which is really scary, and I think probably guys like you, Casey, wouldn't have that because you've done a lot of extreme stuff, and if it was going to happen, it would have happened. But anyway, apparently 50% of those have very high LP little A's over 100. And so if you got that, you want to go into like, hyper alert on dealing with it. And statins don't really lower the LP little a. You only have to do it once because it's kind of a genetic thing, that, if you got it, you got it. But some of the newer, PCSK9 inhibitors apparently lower it like 30 to 40%, and other things you can do can lower it. But heart disease is not something to totally ignore. A lot of lifestyle stuff makes a big difference. Obviously, good muscle mass, good quality muscle, good muscle percent on DEXA scans and stuff like that. That all correlates with good outcomes with all four of the chronic common diseases. But within that, if you can optimize that, I think it's not a bad idea to do it. I always remind people, like if I'm going to do a big bike ride, I probably won't take my statin that day. I'll like, take it the next day. And, there's nothing to be said. You can't sort of use it a few days a week. But keep an eye on that ApoB.
Very, very interesting. I really appreciate that very well thought out and thoughtful opinion on that.